Hello, everybody. It's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast. I have my partner in crime, Dr. Erica Riggleman. Hello, Erica. And we have a special guest today. This is Dr. Carrie Jones. She's a naturopathic physician and the director of Precision Analytical, which is a company that does adrenal testing. And she is the go-to person, in my opinion, when there's questions about physiology. And I know that I use the testing that Precision Analytical offers. I used to do saliva testing in the past, but now my gold standard is the testing, the DUTCH test through Precision Analytical, and I tell everybody about it because I think it's so good. And the resource that Dr. Jones is for answers about everything hormones is phenomenal. So Dr. Carrie Jones, welcome to the podcast.
Hey, thank you so much. I'm super excited to be here. Talk to you guys.
Well, thank you. Now, we just saw each other a couple weeks ago. And by the way, happy birthday, right? So,
thanks. Yep. Birthday was yesterday. As you said, I just keep getting younger. So we're going to roll with that.
Absolutely. You are the director of Precision Analytical. The company's been around, 4 years or so now?
6 years, I think. So in concept, it's been around probably 10, 11 years, but actual physical has a building, probably about 6 years.
Okay. So you are the medical director.
I'm the medical director, yeah.
You're a naturopathic physician by trade. Then you became the medical director. But why don't you tell me your story? How do you go from naturopathic director or naturopathic doctor to direct medical director of this awesome hormone clinic or lab? How'd that happen? How'd they come about?
In a very circuitous manner, that's for sure. I know the owner, Mark Newman. He worked for a different hormone lab company for years, so I'd followed his work for years. And I was the medical director for a large integrative clinic outside of Portland. It was owned by an MD. We had a couple MDs, nurse practitioners, physician's assistants, naturopathic physicians. I was one of the medical directors. And so Mark approached our clinic and said, hey, I've got this really cool new test. You guys do functional integrative medicine. Would you be willing to give it a shot? And I thought the world of Mark. And I said, I'm happy to help you. It's this new startup company. If you need help reviewing comments or tests, or if you need a person to bounce ideas off of, I'm happy to help. And he said, I can't pay you yet, but I can give you lots of free hormone testing. So it just grew from there. And over the years, just slowly, he just convinced me that the lab needed my help, and that's where I wanted to be. So it was great. It's a great fit.
And I would agree. The lab did need your help because we needed somebody like you to talk to on a regular basis. I'm sure Mark would be fine. You're a gem to talk to and a wealth of knowledge. So this is a Thyroid Answers podcast, and we talk. So most of the people in our group are people who have thyroid problems. They're tired, fatigued, and we really focus on what's going wrong in thyroid physiology, and maybe what's a little bit different than most people might hear from their traditional, conventional doctor or endocrinologist about thyroid physiology. And we really have a bend towards what's happening at the cellular level. But a lot of our patients can come to us with hypothyroidism. They're tired, they're fatigued, their hair's falling out, and their skin's dry. And they may go to their doctor and their doctor may say TSH is normal, T4 is normal, you're just nuts, crazy, or lazy. Or maybe you have something called adrenal fatigue. Can you explain to the listeners how maybe the symptoms of hypothyroidism and compromised adrenal function, maybe they're pretty similar, and the tie between the two systems?
Yeah, absolutely. So the thing with adrenal fatigue, as you both know, because I've talked about it with both of you, is it all starts in the brain. The adrenals get told instructions from the brain. So if the hypothalamus and the pituitary aren't communicating, the adrenals are not going to make cortisol. The symptoms are real with adrenal. They're very, very fatigued, but where it starts is actually the brain. Then on top of that, the adrenals take a lot of input from the thyroid. The thyroid is a little more mastery of a gland compared to the adrenals. And so if you're having thyroid issues, either right in the brain, you start in pituitary, or cellularly, which I know you guys have talked about on prior podcasts, it directly affects the adrenals. And so now you have this chicken and egg thing just perpetuating, and you have all the same symptoms. You're very fatigued, you have problems with your menstrual cycle, you're losing hair, you're gaining weight, you're having GI issues, and they just roll into one another. The thyroid is slowing the adrenals down, and the adrenals are slowing the thyroid down, and people feel terrible.
It's almost and to some degree, when there's chronic inflammatory issues going on, there is this kind of protective mechanism to really kind of sometimes shut the system down, to really kind of slow metabolism down, slow everything down, so that the person could kind of rest, heal, and repair. And unfortunately, we don't listen to those
ever.
So what we do is we jack ourselves with caffeine or stimulants of some sort and try and just keep going. And that can really exacerbate the problem.
Right. And we call it burnout, right? Like you keep burning the candles at both ends, or I feel like I've had adrenal burnout or thyroid burnout. And you're exactly right. It's the brain sending the communication like, okay, we're going to stop this now. I'm going to slow this down. Or it's the cells in the periphery. It's the cell in my little finger that's going, yeah, we're going to downregulate those receptors. And so even though thyroid hormone is floating around, there's nothing to bind to. So it can't do anything. And it's all protective. But like you said, we never listen. You just keep pushing.
Yeah, so when we're looking at your test, a lot of patients, when they come in, they've thought that they've had adrenal fatigue. And so they've gone to other functional medicine doctors or even medical doctors who may do, specific adrenal testing. What makes the DUTCH test a little bit different from saliva versus, blood testing?
Absolutely. So DUTCH is an acronym. It stands for Dried Urine Test for Comprehensive Hormones. So collection is different right off the bat. You urinate on a strip of paper, let it dry, and mail it in. But because it's a urine test, you get what's called the metabolized cortisol markers. And you get the free cortisol just like you would in saliva. So you can watch your up and down pattern through the day. So high in the morning, get your butt out of bed, low at night so you can sleep. But then on top of that, you get the metabolized cortisol. Metabolized cortisol represents about 80% of cortisol made in total. And so you get an idea of, can you even make cortisol to begin with? Do you make too much? Does your body overshoot? Do you not make enough? Is your liver maybe overprocessing or underprocessing all this cortisol? So you get this much bigger picture with the DUTCH test. And then you get cortisone. Now, cortisone is inactive. It will mostly inactive. It's like 90+% inactive. But the body can flip between active cortisol and inactive cortisone. And so by looking at this test, you can see, 1, how much do you make? 2, how much of it is free? And 3, how much of it is really active or being deactivated to cortisone? And then you can address it in those 3 markers more of a individualized manner versus just, oh, here, take this herb. It's good for everything. Like, well, no, maybe not. We're going for an individualized approach.
Yeah, and that's what I love. I personally love the DUTCH test because you get so much more detailed information. It's not just a blanket overall, okay, here's what your cortisol numbers are. And oftentimes, when I used to do saliva testing, everybody was coming back low. And now when I'm running the DUTCH test, I'm getting a mix of, okay, yeah, you're not making cortisol, but let's look at that metabolized cortisol and you're getting a little bit different picture.
Right, absolutely. And as Eric alluded to earlier on, believe it or not, on adrenal testing, if you get this big picture, you can pick up thyroid patterns that may have been missed in blood work. If you're just getting the very basic thyroid TSH tested, now you get the DUTCH test done, you're looking at all of your big picture cortisol. The adrenal glands and the thyroid glands play off each other, and it shows up in the results.
So I think there's a couple really important things I want to make sure we kind of go over. That when somebody gets saliva testing, is they're just looking at cortisol, and when we think about we're looking at this free cortisol, which is like free T3. It's the active form. It's good to go. And when we look at when we do the DUTCH test and we do the urine test, we can look at cortisone, which is like the deactivated form, which is like T4, right? So there's a similarity between cortisol and cortisone, T4 and T3, and T4 and T3 in the thyroid physiology picture.
Right.
You need to have both, and there needs to be a balance in both, not just one or the other. And if you only looked at T4, you wouldn't know what's happening with T3 if it's being converted into reverse T3, so you don't get the full picture. Right. The benefits of the urine is you get the full picture of, do I have enough cortisol in total? Am I metabolizing my cortisol, meaning can I make it and can I get rid of it? And then do I have some inactive reserves for when I need them, or don't I? And do I have enough good stuff floating around the system? Is that a good summary?
You nailed it. It's like you've done this test once or twice.
Maybe a few times, yeah. So if we talk about one of those things that a lot of times people do come in with, is they'll come in with their saliva test, and they may come in and say, hey, my doctor said put me on these supplements or medications for adrenal fatigue.
Mm-hmm.
You've talked many times, and I think it's worth explaining this again to the people listening and watching. That adrenal fatigue, the fact that the gland can't make cortisol, is not really what happens in the body. That doesn't really exist.
Right.
Can you explain that in a little bit of detail? What adrenal fatigue is or isn't, and why it can or can't happen?
Well, my proposal is that we come up with the news as a group. We come up with a new name for it. Either HPA axis dysfunction or something along those lines. Because adrenal fatigue, just like you said, is the notion that the adrenals have completely given up the ability to make cortisol, and therefore they don't. The cortisol levels are very low. Now, if you have the autoimmune condition Addison's, which we're all familiar with, that is true. It's a true autoimmune destruction of the gland. You can't make cortisol. Addison's is not very common. But so what happens more commonly is that it starts with the brain. The hypothalamus tells the pituitary to tell the adrenal to make cortisol. And if there is a miscommunication from up here down to the adrenal glands, then you're just not going to get cortisol. Now, you will test whether it's blood or saliva or urine, and your free cortisol levels will look really, really low. Absolutely. But it doesn't mean necessarily the gland itself has given out. It's entirely possible that the communication has given out. So the brain has either chosen not to, or it can't. It physically can't. There's something blocking it. And therefore, cortisol is not made, and people are very, very tired. So the symptoms are real, but just the mechanism of action we all thought happened is not entirely true. It starts a little bit higher up. We need to go high.
So could a person have a normal cortisol level or a very low cortisol level on a saliva test or even a urine test, and you could look at cortisone, the inactive or deactivated is what I should say, I guess, the deactivated form, and that could be high. They could have lots of deactivated cortisol.
Yep. Yeah, absolutely. And so then if you don't have that information, you may be treating them inappropriately. You may think, oh my gosh, it's quote unquote adrenal fatigue. Your adrenals have given out, when really the adrenals are fine. The body is just deactivating to cortisone, which is a different treatment than if the adrenals have truly given out and you don't make cortisol. That's a much bigger issue. If the body doesn't make cortisol, that's survival, life or death. If you're just making a lot of cortisone, it means you need to slow down and take care of yourself. The body is forcing you to slow down and relax if you're making cortisone. And the same goes for metabolized cortisol, which we talked just a little bit ago. You can have very, very low levels of free cortisol, let's say on a saliva test. You run a urine test and find out they're making thousands and thousands and thousands of metabolized cortisol. So it's not a production problem. It's a free problem. It's what's available. So they have tons of product, but none of it's free. None of it's out there.
Yeah,
and so yeah, go ahead.
I definitely see this with the patients who coming in. We run the adrenal testing. Their overall cortisol looks in normal range, but then you look at the metabolized and they're sky high when you're looking at that dial. Mm-hmm. And they've got tons of inflammation, and they've got parasites and bad bacteria and leaky gut. And so all that inflammation is playing into that. And if you don't run this test to look at metabolized, you may think that their adrenals are, working perfect.
Right. Exactly. It can be misleading if you don't have all the information. Just like thyroid, if you don't have all the information for thyroid testing, it's totally misleading.
Right. Yeah. People look at TSH, T4, and we've talked about this multiple times.
Mm-hmm.
TSH really only represents the saturation at the hypothalamus and the pituitary gland. It does not represent what's happening at the cellular level. And if you can't get thyroid hormone into the cells at the cellular level, you're going to have hypothyroid symptoms. I mean, that's why people have hypothyroid symptoms in the first place, is because they have inefficient levels at the cellular level. That's what's really the big trigger of, hey, I feel tired, fatigued, I'm gaining weight, all those things.
Right.
So TSH, T4 could look perfect, right? It could look even suppressed like you're hyperthyroid, and you can think, hey, I'm almost hyperthyroid, so it can't be a thyroid condition. Well, yeah, all the inflammatory mechanisms are suppressing the pituitary gland from making TSH. So maybe that's the bigger picture.
Right.
The high metabolized cortisol that we see on a test. So when somebody looks at when we're talking about metabolized cortisol versus with free cortisol versus the cortisone, can you explain a little bit about what the difference of those three things is?
Sure. So the metabolized, I always say it's easy questions. how much do I make in total? That's your metabolized cortisol. Do I even have the ability to make it at all? How much is free? So there's your free cortisol. And then how much is being deactivated? So there's your cortisone. And so you get the big picture, all the questions. Can I make it? What's free to bind? Kind of like a free T3. And then what's inactive, like your T4. And so it kind of mimics what I look for in cortisol, what I'm looking for in thyroid as well, which is really nice because they go hand in hand. I'm looking at big picture.
So if somebody has this picture of low cortisol, right? And they've got elevated cortisone, the deactivated form. What are some of the things that may cause them? What are the symptoms that they might experience? And what are the things that may trigger that?
So the biggest symptom, of course, is fatigue. And fatigue is like your classic symptom for absolutely everything, unfortunately. But fatigue is your big one. And then the two big reasons I see all the time, number one is stress. And stress that you've had for a long time, where the body goes, okay, I'm done. Let's deactivate your cortisone. And if you won't slow down, I'm going to force you to slow down. And it will flip to cortisone. I just see that. The number two reason is after acute illness. Like, when you have the flu, you've had the flu, and you're over the flu symptoms, and you think to yourself, okay, I'm strong enough to go back to work. So you go back to work, but you're exhausted all day. That's because the body's still in healing mode. And obviously a lot of other mechanisms play into that. But a big mechanism is you go from cortisol to cortisone, again, to get you to slow down, rest, and heal. We don't listen, but those are the two big things that I see all the time when the body prefers cortisone.
So that's kind of similar to, and I know you've read it, we've talked about it in different lectures at different places, the cell danger response in Dr. Navio's paper, right? So under that cell danger response, when the cell feels a threat or senses a threat, it's going to decrease cellular metabolism. It's going to decrease glucose transport. It's going to decrease thyroid transport. It's going to dump cytokines out of the cell to alert other cells. It's going to dump genetic material out, which could possibly trigger, it's going to trigger cleanup mechanisms, potentially trigger immune issues. But the same thing's really, based on what you're saying, is really happening with cortisol too. The body during that, maybe that similar cell danger response, acute phase, it's going to use what it can do. But in the chronic phase, it's saying, all right, that's enough already. Let's shut the process down. Let's try and make the cellular system, give it a chance to heal and recover.
And like Erica was saying earlier, in an acute phase, you may find really, really high levels of cortisol, especially metabolized cortisol. Just like she said, you may have a lot of inflammation, gut bugs, pain, infection, Lyme disease, things like that. And cortisol is anti-inflammatory to a point. So the body says, all right, there's this massive infection in the body. Let's clean it up, jacks up the cortisol. And then, you can only sustain that for so long. And then gradually over time, the brain says, this is enough. I'm done with this. And it starts to fall.
Yeah. So acute phase, we want to see it elevate, but chronically, we're going to see a drop.
Yeah, damaging.
And if somebody didn't know, they may just start giving them adrenal stimulants. In that case, what do you typically see? What should somebody, like a listener, if they're listening to this and saying, well, I had low cortisol, my doctor put me on some adrenal stimulants to try and help, what kind of experience what kind of symptoms might they experience from that type of situation?
Usually the two biggest things I hear the most are increased anxiety and increased insomnia, right? Because they're tired but wired, and now you've just wired them even more because you thought their cortisol was low, their free cortisol was low, when really that wasn't the full picture. So you put them on stimulants and their wired goes through the roof. They're like, they call the office. Oh my gosh, I'm so anxious. My panic has gone up. I can't sleep. I can't stay asleep. I'm waking up all the time. I don't understand what's wrong with me. I feel jittery. My heart is racing. I'm having heart palpitations. Usually that's what comes back, and they tell me they just don't feel right.
So there's a combination of factors where they jack the fight or flight hormones a little bit, and to some degree inhibit clearance, right?
Yep, absolutely.
So speaking of sleep in the adrenals, how does cortisol directly affect the quality and the quantity of sleep that a patient would get?
Yeah, absolutely. So I always say cortisol is like the sun, follows the sun, and melatonin follows the moon. And so your cortisol is supposed to be up in the morning to get your butt out of bed, and then it's to fall gradually through the day so you can fall asleep. And as cortisol goes down, then melatonin comes up to help you fall asleep and stay asleep. Now, it's called a circadian rhythm. as we know, we get in this day and age, we get these disruptive circadian rhythms. And now people are doing stuff before bed they shouldn't, myself included, maybe, like playing on their phone or on their tablet or on their computer, or doing last minute work stuff that they forgot, or they're making the list, everyone's catching up and running around and in these bright lights. And so cortisol goes back up again and melatonin goes down. And now it's 10 o'clock, 11 o'clock, midnight, and people can't sleep. And as we know, if you don't get restorative sleep, you wake up, well, feeling like crap, but you also wake up not repaired. All the cells in your body don't get that restorative, reparative sleep. And the cycle just starts all over again.
Yeah, and to add to that, then when you wake up in the morning, you're getting artificial light all day long. You're not actually getting real sunlight, and so that plays a role in the way that the body recognizes real light versus artificial light too.
That's a great point, especially not you two, but I happen to live in the not so sunny Pacific Northwest, where it is this weird gray color all the time. And so definitely I really encourage those, what are those lights called? The full spectrum lights during the day, and then doing the blue blocking, ever so sexy orange sunglasses at night to really train the brain, train the circadian rhythm back in the body. Or if you live in a sunny place like you guys are having real summer, I'm currently in pants wrapped in a blanket. You can't see, but because it's cold here still. So you guys can actually go outside. You can tell your patients, hey, in the morning, go outside, get real sunlight exposure in the eyeballs. And then at night, be dark, close your curtains, and that'll help train the circadian rhythm.
So there should be we should talk about something that kind of goes along with that, right? And the adrenals probably play an important role in this. And maybe it's a good thing to talk about since we're on sleep. And you can explain to our listeners why this happens. But really commonly is the person who says, I wake up about 2, 3 o'clock in the morning and I can't get back to sleep, right?
Right.
We talk about adrenal problems. There's problem A is I can't fall asleep at night, right?
Mm-hmm.
You just touched on that one. But the other one that some people, and especially the older they get, they start to consider it's a normal situation because they have to go to the bathroom. And
Right.
I know I'm always telling them, I know Erica's always probably saying the same thing. You're not supposed to wake up at 2 or 3 o'clock in the morning to go to the bathroom. You're not waking up because you have to go to the bathroom. You're just not in a deep enough sleep. So how does the adrenal system and cortisol play into that nighttime waking?
Blood sugar is a big one, which you guys probably talk to your patients about. So the number one job of cortisol is to manage blood sugar. It's a glucocorticosteroid for a reason. Gluco for glucose, cortico because it's made in the cortex, and steroid because it's a steroid hormone. So if you are having blood sugar issues, then the adrenal system turns on at night when it's not supposed to, technically, and it will wake you up because your cortisol is trying to manage the blood sugar problem. And so you wake up as a result to get up and go do something about your blood sugar situation. Then when you wake up, you think to yourself, why did I wake up? Oh, I think I have to pee. And then you get up and go to the bathroom. When really it's potentially an adrenal blood sugar issue, especially with alcohol. We see this a lot. People will have a glass of wine or 2 or 3, or they'll have a cocktail at dinner before bed, and they go to bed and there's all that sugar coursing through, and it's one of cortisol's job to help with that balance. On top of course, all the alcohol comes through the liver, and the liver's dealing with that as well. And so you wake up at that time. It's sort of the prime time. And then you can't fall asleep because you've now woken up your system that's supposed to be in the deep REM sleep. And then it's a vicious cycle. You train your brain that you wake up at 2 in the morning, and you keep telling yourself that I wake up at 2 in the morning. I wake up at 2 in the morning. And the brain goes, okay, that's our new normal. Let's do it.
And so if you had somebody who was struggling with waking up at night, if you had 3 or 4 things that you could give them as advice to kind of calm that cascade down, or that process of waking up at 2 or 3 o'clock in the morning, what would you give them as some guidance to say, hey, these are the things you probably need to do first?
Oh, this is a good question, because I want to hear what you guys say too. I'm always learning. So the big thing I always say is, sleep hygiene, wind down, get off. I mean, I'm guilty. Get off your phone, get off your tablet, or get the glasses. I am a big fan of the calming. There are a lot of great calming herbs or sleepy time tea, things that can help train the system to shut down. So if it's too wired up at night, sometimes we do need a little help with herbs or with teas to calm that system down. And then obviously dietary. So what you eat for dinner and dessert will greatly affect you 4 to 6 hours later. And that's when you should be sleeping. So be really, really careful and mindful, and stick to healthy fats and protein and lots of veggies, and limit alcohol. And now, I'll be honest, yesterday was my birthday, and I I had 5 pieces of cake. So I didn't sleep that great last night, but I knew what I was doing. It was my birthday. But I don't do that every day. So that's, I tell patients the same thing, be mindful, because karma, she will come back and get you at 2 a.m. and wake you up.
Right.
What do you guys say? What are your go to bed things?
I mean, lights I think are huge. I mean, I always am pushing that. Big thing I always tell patients, if you can dim your lights, that's really good. You can buy on Amazon these red bulbs that you can put in the bedroom, so you're not getting the bright blue light. You're actually getting a red light, so you can still move around and see things, but you're not getting, bombarding your retinas with those bright blue lights. I always, if people are having troubles falling asleep, Epsom salt baths. The warming will be calming. The salts, the magnesium in there will help kind of calm you down, help for sleep. And then if people are waking up in the middle of the night, I'm always in the back of my mind thinking we've got some sort of chronic infection, whether it's parasites or Lyme disease, because those tend to be a little bit more active during the nighttime, which can wake people up.
So I copy what you guys both said. I'll go with something a little bit different. Definitely from a dietary standpoint, if they're struggling through the night, I'll tell them that probably if they're going to do a bit more carbohydrates, probably push those towards the evening a little bit more. But I really am a big advocate, as our buddy Mike Mutzel is, of breathing and mouth taping for people. I think a big reason that people wake up at night is they're terrible breathers. During the night, they're opening their mouth, they're breathing through their mouth, they're creating chronic hypoxia, and that's creating a chronic fight or flight response to constantly wake their brain or slightly wake their brain up to get to restore breathing, because when they're breathing through their mouth, they're creating that hypoxic state and their brain's just not getting what it needs. That'll jack your cortisol, that'll jack your adrenals, that'll jack your epinephrine, norepinephrine. And so what I try and get patients to do, besides the dietary stuff, besides getting their bed ready, besides doing the lights, is get them to really retrain their breathing. So I'll test them in the office with a controlled breath hold time test. And essentially what we'll do is have them close their mouth, breathe all the air out of their nose, pinch their nose, and hold that till they get their first sense of anxiety or panic, where they feel like they got to swallow or just they get a little stressed. It's not how long they could possibly hold it, but until they get that first sense of stress. And usually while I'm watching, I'll look for them to swallow, or I'll look for their neck muscles to twitch a little bit. If they're less than 40 seconds, they're not breathing well on a regular basis. That's a good sign that they're not breathing well. So I'll get them to start doing breathing exercises, start to work on, definitely during the day when they can, as long as nobody's watching them, to keep their mouth closed, and then do things like close their mouth, breathe all the air out of their nose, pinch their nose, and try and walk in circles, or go out for a walk and hold their breath as long as they can, and then recover through their nose again, not opening their mouth. And then in the evening, try and get them set up to start walking around the house with just a piece of tape over their mouth, so they can kind of get used to that sense of not having their mouth opening and not breathing through their mouth. And then once they get comfortable with that, then start doing that mouth taping at night. And although people give me a lot of grief initially about that, when you do it and you get kind of used to it, you really do sleep a lot better. And especially if they've got chronic inflammation, if they've got chronic infections, their soft tissue is going to swell at night. If they're hypothyroid, they're already having soft tissue inflammation and swelling. So those passageways are going to be narrowed to begin with. Add on top of that any lousy diet before they went to bed, sugar, all those things will get magnified. So I think one of the best things I've seen, besides support products to help with calming, like Cabanase or GABA support products or Magnolia or things like that, just getting them to start retrain their breathing. And it's free, and that's the biggest thing. It's crazy that the stuff that's free is the hardest thing.
I know.
It is. It is. And it really
I actually have the tape at home. I just got it on Amazon. It's sitting on my bathroom sink upstairs, so I got to start doing that.
It's not very sexy,
Yeah,
but it works.
It's not. You want to do all that stuff first and then put the tape on.
Right.
So there is, I know we're going to run out of time quickly, but I want to kind of get through some things. We're both big fans of the DUTCH test. It's a urine test, a dry urine test. Can you explain a little bit how people do it, how that process works, and then how they can go about getting that test done?
Yeah, absolutely. So it's a super simple, easy test. Like I said, the acronym stands for dried urine test. So it's these little pieces of filter paper, and your patients will urinate on them first thing in the morning, a different one 2 hours later, around dinner, and before bed. So it's 4 times through the day. If they do happen to get up in the middle of the night, if they have not yet followed your advice and they get up in the middle of the night to go to the bathroom, then they'll do it a 5th time and let everything dry about 24 hours and mail it back to the lab. And so it's pretty easy collection. And then when they get the results back, we've talked a lot about adrenals, but you get all your basic hormones as well. You get your estrogens, you get your progesterone, you get your testosterone, you get your DHEA marker. We call them androgen metabolites. So it's the metabolites of DHEA and testosterone. Much like cortisol, just gives you a bigger picture. What are your androgen hormones doing? Estrogen, we give estrogen metabolites. What are your estrogens doing? Are they going down the healthy pathway? Are they going down maybe the cancerous pathway? Right? Can your liver clear them effectively? So we give that information as well. Melatonin. And then a marker we haven't discussed, but real quick, is what's called 8-hydroxy-2-deoxyguanosine, 8-OHDG, which is a super big fancy name for how much oxidative stress you have in your body that is causing DNA damage. So it's a real great marker for infections, chronic disease, degenerative disease, and cancer. And website, well, first of all, I highly recommend people find a qualified practitioner that knows how to do the DUTCH test, as you two know. The test is involved and gives a lot of information, so people can call the lab if they want to, and we can refer them in the direction of the state they're in or the city they're in. But if they go to DUTCHtest.com, DUTCH, DUTCHtest.com, they can learn everything on there. They can buy it. They can buy a kit and watch videos that are free, all about what comes in the results, things about adrenals, things about hormones, just basic overview stuff. And so that's where they can go and how they can learn more.
So they could work with a functional medicine practitioner who can order the tests, like Dr. Eric or Dr. myself.
Yeah, which is our primary that is the number one thing we recommend. Hey, find somebody like one of you two, work with you guys, because otherwise you can order it online. The lab itself, we do not give medical advice. We always refer back to a practitioner. So let's say one of your listeners orders it from us and says, okay, now what? Then we are just going to say, hey, contact, Dr. Erica or Dr. Eric and, become their patient and let them guide you. Or they could have just done that in the first place, and then you would have given them the test.
So they can order the test on their own, but the lab itself doesn't give patient advice.
Correct.
There are plenty of awesome videos on there to learn a bit more about the hormones. And I recommend my patients all go to that site and watch the videos, because there's a lot of information on there. And even if you came in and the doctor sat down and went over those test results with you, it's still going to seem like a foreign language to look at. And to be fair, I mean, there's so much information on there that I don't expect a patient to really understand every aspect. We try and just hit the big points and say, yep, you have a hormone problem. You don't have a primary hormone problem. You have a metabolism problem. Or you don't have adrenal fatigue. You're just converting it to a more deactivated form, and here's why you're doing that. But if they go to the site, they can spend days watching videos and learn a ton.
Right. Yeah,
just kind of going over it and taking notes. So I think it's an invaluable test. It's interesting that you added the 8-OHDG, which is great, because we see that on organic acid testing already, and it's nice add-ons there. Is there any other future add-ons that you can?
Yes, as a matter of fact. Yeah, we have a brand new test coming out. I don't think I've told either of you, but maybe I have. We have something coming out called the DUTCH Plus. Have I told you about the DUTCH Plus? So we're going to combine, we are a urine testing company, but we are actually going to offer the ability to do what's called a cortisol awakening response. It's a much more specific test to look at how the hypothalamus and pituitary manages cortisol in the morning. And we do that with saliva. So we're actually going to offer the ability to have the complete urine test like you're used to, all the cool things we just talked about, and then you add in what's called the cortisol awakening response. And the way you do that is you have a little swab, a cotton swab that you stick in your mouth as soon as your eyeballs open up in the morning, 30 minutes later, 60 minutes later, and then around dinner and before bed. And so getting the cortisol rise within the first 60 minutes of your eyeballs opening in the morning gives us a lot of information as to the ability your body has to make free cortisol, to turn it on. And if you can't do that, those are the people that probably struggle the most through their day. They're the chronic fatigue, fibromyalgia, the inability to fight infection. They're the people with your chronic disease that just can't seem to get over the hump because they don't have the cortisol rise to get it going. And it's that rise in cortisol, believe it or not, is what helps with, when the body makes immune system cells, it tests it first for autoimmunity. It's called autophagy. And if it fails the test, then the body, in theory, is supposed to pull it aside and say, okay, you can't go in circulation. You failed the test. It's the rise in cortisol that helps kill those off and discharges those so that they don't get out in circulation. Obviously, that system for a lot of people fails, and we have a lot of autoimmune in our world right now. Mm-hmm. So if you're not getting that rise in cortisol in the first 60 minutes in a healthy manner, you may be more prone to autoimmune disease. So it's sort of this next level detail test that we're going to start offering very, very soon, as a matter of fact.
If they did a saliva test, that one piece may be on there, or is that a totally different test than what we see on saliva?
It's a totally different test. So typical saliva testing for you guys and your listeners, usual saliva testing is in the morning, at lunch, at dinner, and before bed. So you miss that 60-minute first thing in the morning. So it's literally in increments, 0, 30, 60 minutes. So it's very, very fast and rapid, which is why it can't be a urine test, because most people can't pee first thing in the morning, pee 30 minutes later, and pee 60 minutes later. Well, some people can, but it doesn't give you the information you're looking for. So that's why we have to do it with saliva, and we're doing saliva cotton swabs.
Excellent.
So we're blending.
And is that test, so that's going to be, not only is the urine test unique to Dutch, but this testing will be a bit unique to Dutch as well?
Very unique, yeah. As far as we know, there's one other company doing just the cortisol awakening part in saliva, but they're not a urine company, so they don't give the metabolites, cortisol, estrogen metabolites, androgen metabolites, melatonin, 8-hydroxy. They're not giving everything else. So we're trying to offer the best of both worlds. Give that 60-minute, how well is your HPA axis work, on top of everything else you can get in urine.
That's awesome.
For those patients who need it. Not every patient needs it. Not every patient is, cortisol is not their thing. That's not their problem. So they don't need this fancy test. But for a lot of people, you may find this is the next level, deeper information, why they're not getting better.
So for the practitioners who might be listening, since you brought it up in this test, right? Who would be the person that they would say, maybe I need to do the plus portion of that?
Yeah, absolutely. Definitely, if you suspect chronic HPA, hypothalamus pituitary adrenal axis dysfunction, maybe it's not getting better, it's not responding to things you've been doing, or maybe they're not responding to things you've been doing for their chronic disease or their infection, their autoimmune. This is very much a generalization, but maybe you're more complicated patients, you're more train wreck patients, patients who unfortunately come in, life has not been fair to them, and they need in-depth testing because there's so much wrong. You want to just pinpoint, all right, your HPA doesn't work. You don't rise in 60 minutes. Therefore, here's the cascade. You're not going to be able to fight infection, balance your blood sugar, reduce autoimmunity, things like that. If you're just your standard hormone person, fatigued person, the Dutch Complete, like you two normally run, absolutely, you get great information. That's what you're looking for. It's kind of that next level patient that you think, oh gosh, I need to find a lot more pinpoint stuff for them.
And there'll be some specific differences in how they get treated based versus maybe the person we see.
Yes. Yep.
Yeah, that's awesome.
Yes. Yeah, so that's coming. So stay tuned. We're in the beta test right now, and so in the next we're in June. In the next month, this will be out and about.
Awesome.
That's awesome.
Yeah.
So I would love to keep the conversation going, but we both have, or all three of us have things that we have to do. So what we'll do is, since we didn't even touch on female hormones or androgens or any of that stuff, we'll probably we'll get you back for another couple podcasts in the future so we can touch on each one of those topics, but I think we hit that pretty good. Is there, so if we gave a couple parting things that we usually like to give the listeners, like 3 or 4 key strategies, if they've got chronic tiredness, fatigue, what they think is adrenal issues, or if they know they've got adrenal issues, what would be the 2 or 3 key things that you would advise somebody to do? Obviously, reaching out to a functional medicine practitioner is one of the things beneficial, but what could they do that doesn't cost anything, that's kind of free to them, that they could do to improve their adrenal physiology?
Absolutely. I would say the number one thing is to follow all our suggestions for proper sleep. If they're not sleeping, then they're just not going to get better. They're not going to heal. And most everything we talked about was very, very low cost or absolutely free. And I would start there and be diligent about it. It takes time to reset the circadian rhythm. It's probably taken your listeners and even practitioners years to screw themselves up. It's going to take a couple of weeks to unwind the damage. And so be diligent and get good sleep, and that will help.
Right. I think
it's my favorite.
Sage advice. You got to process time to heal and recover, because it took time to get bad. It's not going to turn on a dime. Prescription medications make you go to bed, make you wired so you can get through the day, but they're not fixing anything in the long run, and it does take work to get better. So
that's true.
Let's wrap this one up. You can go to your podcast. I can run the film around. Erica's got things to do too. So as always, Dr. Jones, we appreciate you being on. You were great. Dr. Erica, thanks for being my partner in crime. Yeah. And we'll sign off. It was great having you on. We covered a lot of material. And we'll touch base on a future podcast. Any parting comments, Dr. Erica?
No, I just want to thank you for coming on, because that's such a hot topic. Plus, it's so wide spectrum, because there's so many different aspects that could be going disarray. And so we appreciate your knowledge and sharing that with our listeners.
Well, thanks. I really, really appreciate it. It's been a lot of fun.
All right, we're going to sign off and look for another Thyroid Answers podcast in a couple of weeks. All right, guys. Thank you.